Hello, and welcome to the Heart of Dentistry podcast. We're looking forward to bringing you the tools that will be so helpful in making your career full of heart and fulfillment. And we are so excited for another episode of the Heart of Dentistry. We are taking the ache out and putting the heart back into all of your clinical and administrative lives. I'm Brandi Hooker Evans, and this is Jamie Marbeau Nichols, and we are delighted to have an episode that I personally am so incredibly excited for because I've spent the last couple of years working very, very diligently to transform my clinical care delivery from the blended approach to ultrasonic only. So I might have just given it away, but Jamie, who do we have joining us today?
Well, it is my honor to have Noel Paschke joining us. She is the ultrasonics guru in our industry. I don't know anyone else that has more knowledge, firsthand knowledge, than Noel, because she happens to be married to an amazing man named Rich that is a ultrasonic engineer. So these two are They're the bomb.com when it comes to ultrasonics and everything you need to know. So, Noelle, thank you so much for taking time out and joining us.
Oh, my pleasure, Jamie and Brandi. So nice to see you as well. I'm really excited about being on your podcast, and in fact, I so excited. I thought I've kind of felt a trembling a little bit earlier in the morning, and it was actually an earthquake that we could feel here in Londonderry, New Hampshire. The earthquake was in Maine, about 40 miles away, and everything's fine. But
It's not a common occurrence to have earthquake.
it is not. So, it was kind of, the big excitement, and, I'm just really absolutely thrilled to be here with you today, and, just to tell you a little bit about the things that I've been working on that I think will make a big difference for clinicians.
Yeah, well, I know it will. And I worked with you once upon a time, and you and I have worked for the same company. We have worked and trained and coached a similar client we shared that I brought you on for the hands-on ultrasonic training, which you still do.
Yeah.
And I have seen you at conventions doing hands-on courses. So definitely anyone and everyone's going to want to get a hold of you when they're done
Oh,
hearing this. So um, one of the things that why I and Brandy wanted to bring you on is because there is some ache in dentistry when it comes around this topic of ultrasonics. What is ingrained in dental hygiene school in our head. In fact, Brandy and I had talked about this, is that instead of it being called the golden scaler, we like to be called the golden insert or something like that. that
to
you
come up with a new award, right?
Yeah, a new award.
Yeah.
Um, and so, one of the things as a hygiene coach that I find hard is that mindset shift for clinicians thinking that they're not doing a good job if they don't use their ultrasonics and their hand scalers throughout the whole mouth. And I would like you, as being the guru of ultrasonics, can you give us some of the pain and some of the things you see out there, and then give us a really good suggestions of things to help shift that mindset. You know, Brandy alluded to it as to what she's been working really hard on, and I've listened to some of her videos and some of her trainings, and she really has dedicated herself to that. I didn't have as hard of a transition at first once I started working for a periodontist, because I really realized that I was wasting my time, to be honest with you, in my hands and my back. So, give us some pointers and some things to help shift that mindset and for our listeners.
Sure. Well, I like to think of things as that we want to connect our head and our hearts and as we practice. And we've been very well educated. And but yet I find so many hygienists go on this guilt trip of I'm not good enough, or I didn't scale enough. And we get so ingrained, I think, in dental hygiene school that we're chasing that little piece of calculus. And somehow if that's left behind, that we take it personally that we're not a good person. Let me tell you, fellow clinicians, you are and colleagues, you are a good person. You are a great clinician. And really, the instruments that we're using are an extension of our hands, an extension of our knowledge, and putting all that together. And so we do it, and it does require discernment. And so, dental hygiene is not a cookie cutter profession. And we approach, as we look at precision medicine, precision dental hygiene, and integrating the oral systemic link, we really do need to look at each individual patient. What are their needs, and how can we best meet them? And of course, we do that in maybe a split second. I mean, it is just amazing how quickly we assess all that information, and then boom, this is what we're going to do. So it is very helpful that and fortunate that we do have instruments that can aid us in delivering really exceptional care. So I feel like one of the pain points and one of like the guilt things for hygienists is that after working for, just so diligently on a patient, and then they realize, oh my gosh, there's still calculus. Well, how can that be? And I look at things on a like instrument integrity. That's what I call it, because we certainly have professional integrity, but we need our instruments to have integrity as well that matches our professional integrity. Now, the good news is there are some really great companies that provide hand instruments for us, whether it's through their metallurgists coming up with better ways to process the stainless steel or sharpen free, a number of different things that we have available to us. But one item I'm gonna put on the parking lot just for a second is that maybe just because those instruments are out there, maybe we don't have availability to them. Maybe the practice owner decides not to buy them. So that is a whole nother pain point that we encounter as clinicians. In the area of ultrasonics, which I know Brandy absolutely loves ultrasonics, and Jamie, you do as well. That and needless to say, yes, I do, and I am a geek. And Jamie, thank you for the introduction and mentioning my husband Rich. We are both geeks, and on a Friday night, you can find us in the lab looking at ellipsis under the video microscope. I mean, we are. And Jamie had been to our home and seen our previous lab, so Jamie, that we are
Oh,
very
yeah.
geeks. We are
It's really
totally.
cool, though. It makes me feel like a geek too.
Oh, good, you are. We'll make you an honorary geek. But in this geekiness, and thank goodness that we've had the research that shows the benefits of using ultrasonic therapy. And there are, of course, as you know, two types of ultrasonics. One is magnetostrictive, and that would be your Cavitron type of ultrasonics. The other type of ultrasonics is piezoelectric. And both are ultrasonic. Both have received excellent reviews in the literature as far as being beneficial, being compared to hand instruments. And, this really started, the research on this started in the mid 80s. And one of the major researchers was Dr. Connie Driscoll, who had been a hygienist, went to dental school, then perio, and then became dean of a dental school. And Dr. Driscoll really was a leader in this area, looking at the research of using ultrasonics. And thank goodness we have that so that we can save our wrist, save our arms, shoulders, and there are technique differences between the two technologies. But I think that it's we're really at such a great time right now in what is being offered to us as far as instruments are concerned.
I agree. I agree. And I I know that you're going to explain it to our listeners what would make a clinician decide between this and this in that split second.
Sure. So we always we start with our process of care, and very well documented by the American Dental Hygienists Association in the first phase, in the assessment phase, looking at the patient, considering their medical history, certainly considering their gingival tissues, pocket depths, bleeding on probing, all of our assessment data, and any deposits that they may have. So we do have, fortunately, ultrasonic instruments. I'll just stay on that topic. We have ultrasonic instruments that can address super and subgingival calculus very well. There are also ultrasonic inserts that can address deposits around implants. But I'm going to say this right up front: please, 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 never use a stainless steel insert or tip on an implant. That there are some that are titanium, that are excellent. There are others made out of PEEK, other made out that have a material called PEI. They are all safe on implants, but just please don't use your stainless steel ultrasonic tips or inserts on those implants. So, in your mind, in your clinical mind, you're assessing immediately, is this patient a super only patient or is a super sub combination? Is it a light situation? And regardless, let's say there's no calculus, but you want to deplaque. And so fortunately, we do have inserts that are thinner and that are ideal for any patient. So, that's the beauty of using ultrasonics, that it can be beneficial for every single patient. And, a lot of people still subscribe to the thought, well, I can't use it on pediatric patients. They have large bulk chambers and I can't use it because of heat buildup. If you're building up heat, I would really encourage you to get some coaching because you're staying in that area too long. Your water may not be appropriately adjusted. But we know, and I think the three of us have seen that we certainly have seen pediatric patients that have calculus as well. So when I say all patients, definitely it could be applied to all patients. I think one of the pain points that comes in for us though is that we have expectations of products, which we should. I mean, whether it's a hair product or a facial cream or an ultrasonic, device, that we have expectations of what it's going to do. And then sometimes what happens is that the equipment that we're using or the tips or inserts that we're using are no longer meeting our expectations, meaning it just doesn't seem like the calculus is coming off. And how can that be? I mean, these instruments are rotating in 1 second. Boom, 1 second. They are vibrating on average about 30,000 times in 1 second. So what's going on? I mean, why am I feeling like I've got to push harder? Why am I feeling like it's taking me too long? And there's a reason for it, that the inserts and the tips, they wear and the metal actually wears. And so when it's worn, and it doesn't matter whether it's magneto or piezo technology, when it's worn about 1 millimeter, you will have a decrease down to only 75% efficiency. If it's worn 2 millimeters, then you may only have 50% scaling efficiency. So now here I am, the good clinician. I'm trying to do my very best. I've done my assessment. I'm using my ultrasonics, but it doesn't have the integrity anymore. I have the professional integrity, but my instruments no longer are serving me or the patient. So that becomes a potential for harm to the clinician because we squeeze tighter, we push harder. That could result in injuries to our wrist. It is an injury to the patient because deposits are typically being burnished. Those nice little smooth bumps on the root surface. Here's where it concerns me, Jamie and Brandy. It's like, what is the risk to the practice? Because now the clinician who has been provided instruments by the practice owner, and if they're only 50% efficient at removing the deposits, that could potentially be a problem for the practice. And it in the ways that now you build the patient or third party payer, but you really haven't delivered on the services. And, we have a code of ethics, dental hygiene code of ethics. The Dental Association, ADA, has a code of ethics as well. And so it's really important that we are living and operating within that code of ethics. So the good news is that there is a product that's been on the market for about a year that even though it's wearing, it's still operating at about 100% efficiency up to 3 millimeters of wear, which is awesome. Wow is right. Yeah, it is the wow factor. So that brings me seriously a lot of joy, a lot of excitement that I can still be the exceptional clinician that I want to be. I want to give the best to my patients, every single one of them, whether it's the first patient in the morning or the last patient of the afternoon. I want each of them to get my very, very best. Mm.
Well, you bring up such a good point, and, so I am a practice owner here in Pocatello, Idaho, and for everyone listening, whenever you heard Noelle say, it's a risk to the practice owner because the practice owner is the one that is providing these instruments, I would encourage you to then take your brain to the next step, which is your practice owner almost every single time wants to make sure that you have the instruments that you need. They have no idea. They don't know if your instrument is spraying too much water. They don't know. I mean, I will sit down in a room at the Aaron, maybe my husband that's the doctor, maybe has not scaled in that room for a decade. He might not have personally been doing hygiene care for more than 10 years. So if you have instruments or anything that isn't working correctly or is worn, please, please, please don't internalize that as I don't have what I need. Take that next step to my office, my team, my owner, my boss, whoever you're talking to. They don't know that that's the case. So please remember that so that we can have a conversation together and talk about the best way to have the instruments available that we want and need.
It's a lot of assuming that goes on sometimes when it
Yeah.
comes to spending money
Mhm.
in the practice. There's a lot of assuming, and I know in one of our previous, conversations, you brought up this whole point of you going in and subbing for one of the hygienists in your practice, and you sitting down and this ultrasonic was just dripping all over the patient and da da da. And you had gone to that hygienist and said, how long has this been dripping like this all down the side of the face of the patient? And anyways, and she said, well, I didn't think we could afford, I didn't think that we, and your husband said, I need to know these things, So a lot of it is assuming, a lot of it is lack of communication. I want to ask you, Noelle,
Yes.
one size doesn't fit all.
No.
We're just going to stick with ultrasonics because that's our talk. So we're going to put hand instruments over here in the parking lot, like you said earlier.
Yeah. All right.
One of the mindset shifts, and I even had a hygienist, one of my clients, say this to me, because I'm a big proponent in left and rights.
Mhm. Yes.
And so she said, why would I take the time to change out the tip? I just want a universal one that I can use on all the teeth. And I gave the example, and I want you to give some more of the knowledge integrity to this to help this mind shift change. I said that would be like your doctor never changing out the burrs when they're doing a crown prep because they want a burr that just does it all. That gets the margin, that takes the bulk off, and that's not what your dentist would do, your doctor would do. So why do you think that that mentality fits for inserts? Talk to us a little bit about that. And
Sure. And Jamie, I've heard exactly the same thing and going into offices and training, and we if we could hear that clock ticking in our head of a tick tick tick, it's like we're such under time pressure. However, how can we harness that time to actually deliver exceptional care? And so what it comes down to is we need to have access. The tip, and I'm going to tip, I'll insert, I'll use this interchangeably. Tips are typically piezo, inserts are typically magneto. But anyway, for the instruments, the ultrasonic instrument that you're using, is that it needs to have access. And so access not only to the anteriors, but to the posteriors. The other thing, it needs to have adaptation because as we know that the root surfaces do become more complex as the disease progresses. So with that in mind, we go back to our assessment. Is this a simple prophy, or is this someone who has more advanced disease? We've done our classification. We know we've looked at the x-rays, we've taken in all the information. So let's say it's someone that has a more complex root anatomy situation. And as far as changing the inserts is that you come up with a sequence. And that sequence is that I'm only going to change that insert one time. But in my head, what I'm thinking is that those two inserts, I'll use just the idea of that you've got an insert is very similar to a double-ended hand instrument. I mean, you wouldn't just use one end of a hand instrument, you'd use both ends. And so that's what I'm doing, and I'm only changing it one time. So I start with a pattern of, going from the buccal surfaces, then to the lingual on the same arch, then going to the buccal and then the lingual of the opposite arch. And by the time I get halfway through, I need a break and the patient needs a break, typically. I mean, I'm not going to have the ultrasonic power on and applying it the entire instrumentation time. So it actually makes you more efficient because you're doing like surfaces and it can really speed the time up. But unless that's part of your routine, and what I have found is that there are some clinicians that they haven't quite found their kind of like their sequencing groove. They're sort of just like going for the big boulders and, I'm just going to try to get the big chunks of calculus off or whatever. And I think that if we start with them in the headset of, I'm going to use a sequence, and here's what my sequence is going to be. So I'm not going to miss any, any areas, any spots, any things like that. So using the two different inserts, like the left and the rights, really it just can make it come down to even more efficiency. However, as a clinician, we know that what we learn in school that's what we tend to stick with, right? So if you haven't had that experience in school, if perhaps your faculty didn't subscribe to that, you may be of the idea that one insert is going to do it all. I can tell you with some of the piezo inserts that they look like they're a universal, but because they don't have contra angles on them, that as you go posterior with it, what happens is I have observed this that clinicians do what I call the one cheek sneak. One cheek sneak, what happens is as you're holding the instrument, then you get the chicken wing that comes up because you're still trying to adapt it to the tooth. And then your shoulder comes up, and then you rise up on one hip. It is an ergonomic nightmare. And until you start having pain, you don't even realize that you've been doing the one cheek sneak. So even if it's not for the patient's benefit, it can be for the clinician's benefit to use the left and rights. So that's my story, and I'm sticking to it as far as the
Yeah.
rights are concerned.
Explain there's one hard true rule because there's a difference
Mm.
in a magneto and a piezo. They move differently. But there is one tried and honest true knowledge that you need to share as to what they cannot do, the clinician cannot do with that tip or insert. And this is why it's important to understand one size doesn't fit all. And what is that?
Correct. Okay, so I have given up explaining angles because for some reason we just don't like angles. We just don't like hearing, oh, it's a 15-degree angle. Oh, this is a 20-degree angle. And the eyes glaze over and you go, what? I talk about tilt. We know what a tilt is versus an angle. Okay. But here is to answer your question though, and this I will use an angle in this analogy is that if I have a tooth, and we know teeth are not just straight, but if I have a tooth, I never want to go the point directly into the tooth. This is a 90-degree angle. Okay. I never want to do that. So I have to, in my mind, especially subgingivally, and I was just telling one of my new
Why do we excuse me, why do we not want that tip, that point to go into
That's
the tooth?
point because well, think about this, Jamie, is that the ultrasonics in dentistry originally started out in the mid 50s as a cavity preparation device. Using it as a cleaning tool was an accidental discovery, kind of like 3M sticky notes was an accidental discovery. It was an accidental discovery that the Cavitron did a great job of knocking off calculus and stain and taking care of stain, not so great at cavity preparation. So the energy is concentrated at the point, and if that point is going directly into the tooth, you can gouge the tooth, causing then sensitivity. And the patient says, "Oh, my teeth! Oh, there's cold sensitivity." You know what? After I had that instrument thing used on me, I got all this sensitivity. It could have been iatrogenic, caused by the clinician with the point going into the tooth. So then what happens when you're working subgingivally? We can't see. Yes, we are working blindly. And when I explained this to one of my new neighbors, I said, think about this. I said, as hygienists, we take courses on anatomy, human anatomy, dental anatomy. We memorize and we know where every indentation is. We know where the roots of the teeth have two roots, three roots, and we work without being able to see under the gum line because we've memorized like a map in our head. So we also have to then have that tip or that insert, the point and the shape of it. We have to envision where it's going. And here's where I find, Jamie, that people tend to somewhat slack off a little bit. When you're going around a line angle, that's and as you finish going around the line angle, that's potentially the area where you could gouge the tooth. So again, it's putting all the puzzle pieces together. We've been well educated. We've had the courses. It's just maybe a refresh on it to say, yeah, right. I don't want to put that point directly into the tooth because you can gouge the tooth. So thank you for saying that. And then you did mention also, I mean, yes, piezo magneto are different, so the tilt that you use is slightly different. It's not quite as um it with piezo, it's not quite as open as you can with magneto. And the reason is piezo typically is linear motion, magneto is elliptical motion. That means that with magneto, you can use the back. You should not be using the back of your piezo tips. But here's what happens is that in dental hygiene school, we get so ingrained in using a magneto, we think, oh, well, now we can use the piezo just like the magneto. You should not be. So here's a great tip for clinicians. If you hear that loud like screech when you're using your piezo, that's an auditory cue. It's almost like someone telling you, you're on the back, get off the back, use the sides. I think about maybe I've taken one too many flights because using piezo is like the guy that has the lights trying to get the plane to come right into the where you get off, and they're doing this with their lights to guide the plane in. Piezo, you're using the lateral surfaces. The lateral surfaces don't roll over onto the back with a piezo. Um, and but it's so we've got this excuse me, psychomotor type of ingrained in us. So some when I first started learning to use piezo, I literally in my head had to tell myself, "Stay on the side, stay on the side, stay on the side." And when I got to the line angle, I had to literally tell myself, "Roll, roll, roll, roll," and keep rolling, so that that lateral surface now is going to be on the proximal surface. So, we're very skilled clinicians, but we have to there are times when especially if we're learning a new technology. And that's the great thing about having a coach or having hands-on, that you can have someone like over the shoulder getting you that information in a good way, in a positive way to lift you up as a clinician, as you're learning the new techniques.
Yeah. One of the things that I use with that analogy that I want to share, if it's okay, is as to why to use left and rights. Because of the exact what you just explained, is that we cannot have that point ever touch directly to the tooth surface, to the root surface. And what I say is if you took your sickle, one of your hand scaling sickles, and you applied that same reasoning to it, that the highest concentration, you would not be able to get into furcations with a sickle if you could never have the point of the sickle go into the tooth, right? And they'd say, "Oh, yeah, if we're, just trying to interpret what that would look like." So when you're using a universal, a triple bend, whatever, for your multi-rooted teeth where there's bone loss, you can't get into those furcations, and as you said, adapt around the line angles without zapping the
Yeah.
patient. And so I just say, think about trying to use a sickle and never being able to put that point
Mhm.
into the tooth. So,
I like that. Can I use that in my coaching?
absolutely you can, because it's the one thing I that they say, "Oh, I get it," because, they you just can't do that. So anyways, Brandy, do you have a question that you think would resonate as we get ready to close, down our session with, Noel? Is there a question that you have that you think would resonate with our listeners?
So, Noel, why should we pick ultrasonics? Like, why should me or you or Jamie strive to transform our clinical care to be so focused on ultrasonic?
So if we back to the principles of access and adaptation, that access really comes into play because our instruments, although we love it's like the new box of crayons, we get them and they're when they're first sharp and we love them, but the blades on our hand instruments can be rather thick, and so we have the benefit of ultrasonics having even the thickest of the tips are thinner than a hand instrument, and being able to go subgingivally, and I say go where no hygienist has gone before. And so I think that's one of the major differences. And of course, you have the lavage. You also have when I say average of 30,000 times a second, that you're not going to be able to scale 30,000 strokes in 1 second with a hand instrument, where the ultrasonics will. Now, all that being said, if you have instrument integrity, and Jamie, a little bit earlier, or maybe Brandy, I'm sorry, one of you mentioned about wear, measurement. Set up a recare system for your instruments that whether it's on a monthly basis, at least monthly to measure. Or one of the things that you can do, so this product that I mentioned earlier that's at nearly 100% for up to 3 millimeters, it's called Duratip. Parkel is the manufacturer. And it has a performance guide, not a wear guide. It has a channel, so you know exactly where to put it. You don't have to try to guess on the piece of paper. And the great thing about it is that it is autoclavable. So your performance guide and your insert, and they're color coded to that insert. Keep it in your cassette. Keep it in your sterilization pouch, and you can just as you're taking your instrument, do a quick measure to see. The thing is, it only has a one mark on it at 3 millimeters. That's when you should not reorbit it, that's when you should replace it at 3 millimeters. It's still at nearly 100% at that 1 millimeter and 2 millimeters of wear compared to traditional magneto inserts that, like I said, 1 millimeter of wear and you're already down to 75%. And certainly 2 millimeters of wear, it's 50%. If I was taking a test and I got 50% on it, that would be an F. So, we really, that's where now that we have an instrument, we have an insert that has the same degree of integrity as we have, that's available to us in the market now.
Yeah.
Well, and that's the flip side to the data that we're seeing on ultrasonic instrumentation is that 50% more biofilm is being disrupted and removed. That's huge. So if you only get an F on a test because you got 50%, that's terrible. But if you're gaining 50% from wherever you started, then we start to like that number 50 a little bit better. So I think the invitation today to the three of us and to everyone listening is to get curious about ultrasonic instrumentation. Get curious about how are you using your ultrasonic and how are you already using it wonderfully and what could you do with that ultrasonic or with additional tips or even a different sequence like you discussed Noel to transform your clinical care
Right.
to the next level. So thank you for getting us some excitement in the heart of our little picker and scratcher
Yes.
furs everywhere, and,
It definitely helped us take the ache out and put some more heart into it with this topic.
So, yeah, so Brandy, I did want to just do a quick follow up on that. So, when you're at that 50% level, the stroke is only going half the distance. So, you're not getting the benefit of the ultrasonic. I'm so excited that both of you just love ultrasonics as much as I do. And thank you for the opportunity to bring this to your listeners and your viewers.